Hi, my name's Chuck Massey, and I have a vision. Develop a coordinated action plan to minimize hospital readmissions of chronic obstructive pulmonary disease patients in an effort to improve quality of care, decrease healthcare costs, and improve quality of life. Objectives of this program is to establish what is COPD, establish economic impact of COPD, quantify the problem of hospital readmissions, describe the customer base, establish a framework of innovation, and communicate a potential solution. Well, what is COPD? It refers to a group of lung diseases that block airflow and make breathing difficult. There's two primary categories: chronic bronchitis, which is related to airway inflammation and excessive mucus production, and emphysema, which is more of a structural and anatomical problem with the lung itself. Diagnosis is established by thorough clinical evaluation and the performance of pulmonary function studies. Severity of disease is classified using the gold standards, which is basing on the performance of the FEV1 parameter for respiratory diseases. Why should we be concerned about COPD disease management and the hospital readmissions? It's the third leading cause of mortality in the United States. According to the CDC, 32 million patients have the disease. Disease is on the rise. It is underdiagnosed. There's a $50 billion economic impact, 30 billion of which is related to healthcare expenses. There were 672,000 hospital discharges for COPD in 2006, and the 30-day COPD readmissions are on the rise. Today's situation: current 30-day readmission rate nationally is at 20%. Lancaster General Hospital 30-day readmission rate is increasing. In fiscal year 2015, we were at 13%, and so far in fiscal year 2017, we are at 20%. Medicare reimbursements to healthcare facilities is tied to this quality indicator. Enrollment for state and federal assistance programs take way too long. Development of solutions and brainstorming. A literary review of current techniques to decrease the readmission rate was conducted. Presented problem and potential solutions to my colleagues for input and revisions. The optimal solutions were developed after continued brainstorming and review of innovation potential. Current initiatives: COPD Smart Order Set, only available in the outpatient world and underutilized. Pharmacological intervention, poor patient technique and costs of medications. Pulmonary rehab, cost, underutilized, and limited program enrollment. COPD education, underutilized and not always implemented. Non-invasive respiratory support, cost concerns, underutilized, and insurance restrictions. Framework of innovation. My proposal looks at organizational and process innovation to improve care delivery and reduce costs. Reliance on health informatics and EMR to identify at-risk patients. The intended benefit is to reduce healthcare costs by avoiding readmissions, increase quality of life for patients, and improve the quality of healthcare delivered. The pitch. What if we could decrease healthcare costs at the same time improve patient wellness? The current initiatives can control 30-day hospital readmissions for COPD patients lacks coordination and is underutilized. A coordinated model of initiatives that includes the use of respiratory therapist-based health navigators and community-based mobile clinics to reduce the hospital readmission rates for COPD patients. The customer base will include patients, case managers, physicians, respiratory therapists, and home health care connections programs. The new chronic disease management model for avoiding hospital readmissions will have a goal of reducing healthcare costs, promote patient wellness and quality of care. Improvements in communication and coordination of care are essential to solidifying advancement in patient care, except nothing less. Implementation of COPD Navigator program that utilizes the expertise of respiratory therapists to advocate for the patient, provide education excess risks. Increase healthcare database and EMR to identify at-risk population and where they live. Care will be directed initially to these areas of concentration. Establish traveling care clinics that reassess patients 2 and 4 weeks after discharge using portable diagnostic equipment, clinical assessments, and for those that are not accessible to primary care physician or outpatient care. Basis in procedural and technological innovation and health informatics. Intervention components. Teach proper inhaler device usage, early outpatient follow-up after discharge, telehealth care, advanced treatment reserved for inpatient, situations apply to outpatient, education resources available to the patient, receipt and filling of medications prior to discharge, participation in the primary pulmonary rehab program, and the use of advanced medications outlined by the gold standard. Resources required for the plan: 2 navigators, creation of a multidisciplinary team to monitor program effectiveness, portable medical devices to monitor spirometry, oxygen, and carbon dioxide levels, link with state, federal, and pharmaceutical company assistance programs for medication coverage, EPIC, and health informatic resources. Conclusion. Improvements in healthcare delivery to COPD patients is essential to decreasing hospital readmissions. The primary benefits of coordinated specialized care is the reduction in costs, improvement in quality of life, and direct health and quality of life benefits to the patient. Potential reduction in hospital readmissions projected at 28% following implementation of COPD navigators alone. Completion of robust pulmonary rehab program has the potential to decrease readmissions by 38% within a year. Thank you and have a good evening.